Thank you for this invitation. So the outline is, why is the microbiota a target? Current therapies, specific alterations, focus on brain and liver-related outcomes, the clinical trial experience, and what is the road ahead. Let's talk about ARRD and substance abuse disorders in gut microbiota. So the gut microbiota is a very complicated organ. The structure and the function are all very important, and they are associated with multiple changes. Microbiota consists not only of bacteria, but fungi, archaea, protists, and viruses, and that can be affected by multiple things, including diet, alcohol, disease etiology, and organ failures. So it's important for us to control all of these when we are actually evaluating. In alcohol-related liver disease in preclinical models, excellent studies from France and Paris especially, and multiple other places have shown us that there are changes in microbiota in the alcohol feeding model. When transferring a stool from a germ-free mouse to another mouse, alcohol resistance mice to the ones that are not, and humanized with severe alcohol-associated hepatitis with FMT. These have shown changes in alcohol-related disorders across multiple preclinical conditions, which has given us a basis for this talk. There are also changes in patients with bacterial metabolites, including AUD, CLD, cirrhosis, and alcohol-related hepatitis, which shows that not only are the microbiota composition different, but the structure is also different in bacteria, viruses, and fungal communities. Moving forward, as we know, alcohol misuse can lead to alcohol-related liver disease associated through all these stages from steatosis and fibrosis. And these areas which are in the red tell us the areas where alcohol-related liver disease is associated with microbial composition changes in humans, which can tell you it spans the entire gamut from steatosis all the way to liver transplant, as well as from brain dysfunction to alcohol misuse. Moving further, what we want to do is to figure out not only the liver-related outcomes, but the alcohol-related outcomes, because these are the things that will prevent the patients from drinking again, to see if the microbiota changes can be associated with this. So this is the current state of affairs. These are the medications, at least in the United States and EMA, that has been approved. Most of them are not being approved, but a lot of them are not really being used. In reality, very few people, if you look at the top side, get this. When they get this, things are better if you look at the top in the bottom left. And on the right side, you see there are multiple layers in which patients can or cannot affect this treatment. So the behavioral treatment and AUD treatment with medical associated therapy is used in the minority of patients. So we need more things. Could the microbiome be one of those things? Things that have been studied: probiotics, antibiotics, fecal microbiota transplant or FMT, phages, postbiotics, and of course, avoiding alcohol. So again, I'm going to go back and forth. It's not just important for us to change the liver disease, but also the brain that will prevent people from drinking again. So these are the spectrum of new microbial therapies. You have stool all the way through the biologically sourced purified consortia. And on your left-hand side, you can see probiotic, phages, FMT, and postbiotics can potentially be used as well. You have this study in which preclinical treatments have shown multiple changes in microbiota with intragastric feeding models, with models that are the Tsukamoto model, as well as the binge models. So these tell you that at least in the preclinical settings, these could have a role in the microbiota, in the gut microbiota change. What about addiction as a whole? In this study, there was a study done with ethanol and water access. And just to make sure that this was not really associated with ethanol, it's associated as well, but for all addiction, it was also the impact of sweet substances. So if you look on the top left side, the water access and ethanol and water access after antibiotic treatment. Antibiotics, we know, will cut down on the microbiota. And you can see pre-alcohol antibiotics reduced alcohol intake. However, Lactobacillus GG increased FGF21 and again reduced alcohol intake. More importantly, this was abolished after subdiaphragmatic vagotomy. And as I said before, this is not unique to alcohol. It is also something that mirrored the impact on sweet substances, saying that this is something that is important for us to figure out the microbiota in addiction as a whole and not just for alcohol-related liver disease. In this nice study published in 2021, the alcohol-related liver disease in an animal model was completely reduced using butyrate, which, as you know, is a short-chain fatty acid produced by beneficial bacteria such as Ruminococcacea, Lactobacillus that are usually higher in people without chronic liver disease. There was a reduction in AST, reduction in ALT, reduction in CCL2, as a reduction in serum endotoxin after the ethanol-fed mice were also given butyrate at the same time. However, tributylin is very difficult to actually put in humans, and the IV formulation at least lasts for a very small time. So you need a factory that keeps on producing that, and that could be the bacteria. In this study, which is now going to be published in the American Journal of Gastroenterology, using the NIH consortium, the Lactobacillus GG was used in patients with moderate alcohol-associated hepatitis. In this double-blind trial of a very small trial of 38 patients with 21 in LGG and 17 in placebo, if you can see on the right-hand side, there was a reduction in drinking report, which is self-proclaimed drinks per week in the LGG versus placebo. Because it is blinded, it is good to know that these patients, even though it's a patient-reported outcome, this was blinded. So it tells you very provocatively that 6-month LGG or lactobacillus GG treatment reduced heavy drinking to the level of social drinking or abstinence level in this pilot study. In this study, they studied other broad-spectrum antibiotics in patients with alcohol-associated hepatitis, and you found in this small study that there was no difference between the groups. In this larger study that is not yet published, the combination of amoxicillin and clavulanic acid and prednisolone, which is the antibiocore study done in multiple centers in France, again did not improve short-term survival in combination with prednisolone in patients with severe alcohol-associated hepatitis. So moderate hepatitis, AH, maybe severe, no change. What about rifaximin? We know this is a non-absorbable antibiotic that has been used for a long time for traveler's diarrhea and as well as hepatic encephalopathy. In the top study, there was no change in the open label study of rifaximin 550 mg 3 times a day versus standard medical therapy. In the bottom was a study of rifaximin versus historical control, which showed barely significant P 0.049 lower infections and lower liver-related complications. And this study that was just published today actually showed in the Lancet Gastroenterology in early alcohol-related liver disease, the intention to treat was not significant, but there was a reduction in progression with the per protocol analysis using a liver steatosis as well as the FIB4 index. There was also a trend towards reduction in PRO-C3, as you can see on top. On the right-hand side, you can see, unfortunately, there was no effect on the alcohol use per day. All these studies show a mixed bag when it comes to across multiple centers and multiple etiologies, as well as multiple antibiotics and probiotics on alcohol intake. And these studies have currently not published any data regarding microbial change, either structure or function in this study, but we are looking forward to that. What about fecal microbiota transplant? When antibiotics change a whole lot of things, fecal microbiota transplant, as we know, is a healthy person's stool or stool product that can go and potentially replace that with potentially beneficial things. In this case series that was done in steroid-resistant alcohol-related hepatitis, if you can see the top bar, which is top graph, which is in the blue, it was the patients who were given FMT compared to historical controls in the green in the bottom, and there was a significant survival difference. Moreover, there was change in the microbial similarity that went to the donor after 6 months and stayed for 1 year afterwards as well. So there is a precedence in alcohol-associated hepatitis with steroid resistance in a case series that this might work. In a long-term experience, again, this was not a randomized trial. There 35 patients were given FMT and 26 were given standard of care, and they were followed over time. You can see days, you can see the curves diverging again. P was 0.05 as far as the survival was concerned. But the important thing was the relapse. And the people chosen to get FMT, 28.6% relapsed, whereas 53.8% relapsed in the standard of care in those who did not get FMT. Again, this was not a randomized trial, but it actually continues to add to the benefit of the understanding that we have. What about this study? This is an open label RCT of FMT in using nasogastric tube for 7 days in 60 patients per group. And they found the survival in prednisolone was only 56.6, whereas the FMT survival was 75%. However, there was a trend towards more infections in the FMT group. This needs to be replicated in other centers as well, but this is again very intriguing. What about an alcohol use disorder in patients who are not acutely hospitalized? In the study done from our group, we took patients with alcohol use disorder and cirrhosis who were unable or unwilling to quit drinking despite the cirrhosis. And they were randomized 1-to-1 into 10 people who got placebo and 10 people who got enema. And there was a short-term and a long-term follow-up. The short-term follow-up showed reduction in craving, and consumption, increase in quality of life and cognition, and increase in microbial diversity and short-chain fatty acid producing taxa. If you remember all this data that we had studied before about, I presented before about butyrate, which is a short-chain fatty acids, and this was linked with the reduction in craving. More importantly, on the right-hand side, you can see there was a reduction in alcohol-related hospitalization and serious adverse events in the FMT group compared to placebo, and this was safe and no adverse events were noted throughout. And what happened when we actually took this mouse from the human pre-FMT donor material into the post-FMT donor material into germ-free mice and exposed them to alcohol? What we found is the post-FMT receiving mice actually reduced their alcohol intake, similar to what the humans had done, compared to the same humans pre-FMT mice, pre-FMT microbiota, which is in the white. So the purple are post, and you can see both the binge drinking and the daily ethanol intake went down. More importantly, this was decreased in mice who had the actual stool. The germ-free supernatant at pre and post did not make a difference either to preference or or ethanol intake. More importantly, when we did RNA-seq on the highest and lowest drinkers, we found most differentially expressed genes were the intestine, not the brain or the liver, tells you the central role of the gut in this situation. We have started enrollment in this trial, which is a phase 2 double-blind randomized placebo-controlled trial. We're already 10% in sponsored by the NIAAA in chronic liver disease and cirrhosis who continue to drink. What are the future challenges and issues? We need to have an equipoise. The risk is high when there are alternatives available. There is safety and availability of other things. The benefit is high when there are no alternatives available, such as steroid-resistant alcohol hepatitis, patients with cirrhosis and alcohol who continue to drink and did not tolerate other therapies, and should be done with treatment of the underlying liver disease as well. So you just don't put in the microbes and forget about the patient. Continue to do things that would help them quit alcohol in addition to treating their liver disease. What about phage therapy? In this nice study done on the left-hand side, you can see in the phage therapy gave a very precision medicine associated change for cytolysine producing E. faecalis in animal models. So this needs to be done in humans. And on the right-hand side, you can see a lot of routes of bacteriophage administration that could be promising. Currently, phage therapy has been only used for resistant infections because it is relatively strain-specific, but multiple cocktails could be used in the future for this. What are the remaining questions in alcohol-associated hepatitis as well as in alcohol-related liver disease and microbiota? Which patient groups, which time points, which route, which agents, and how long for? The ideal primary outcome should be long-term survival without relapse. So we need therapies over and above the current therapy and not instead. And secondary outcomes ideally should be everything else. So remember, there's a global, local, regional, and individual aspects of microbial treatment of treatment of AUD. And you can see AUD therapy and complementary therapy are individualized treatment, but it is only one part of the broader universe that we need to do to actually take care of alcohol-related liver disease. So in conclusion, current therapies for ARLD are not specifically focused on the gut-liver axis and could have issues with safety, availability, or real-world effectiveness. Gut-liver axis is an attractive target for alcohol-related liver disease. Reduction of alcohol intake and craving has been shown in proof-of-concept FMT and probiotic trials. For liver-related outcomes, conventional antibiotics have a mixed record, including rifaximin with a large trial that was just published. FMT using nasoduodenal route from family member donations have improved outcomes in patients with alcohol-associated hepatitis, but this needs to be done, replicated in other centers as well. Challenges remain in personalizing therapy, but promising approaches, including phages, are being studied. Microbial therapeutics are one part of the multidisciplinary strategy needed for AUD, AAH, and ARLD. These are my collaborators and team members, and merci beaucoup.